Okay, now that I gave you your reading homework, we can dive into the contents. And this is on the background of rapidly changing environment, rapidly changing healthcare environment, where nursing labor, which is still crucial to the prevention and treatment of wounds in general, chronic wounds in particular, and more specifically pressure ulcers, is not there at the same extent and at the same level of skill as it used to be before the pandemic. We have all heard, I'm sure that you have heard, and that you're well informed of the um, where that COVID has caused into the healthcare system, the global healthcare system in general, and to nursing labor force in particular. And there are different types of resignations in the field of nursing care, but um, the bottom line of all of them is that we see less physical resources or less manpower and less skilled manpower. And when you look at financial reports, such as this one published by McKinsey, but there are also many others, you see that this gap between supply and demand of nursing um, resources is only expected to increase unless something dramatic happens in terms of government involvement globally. We will reach very soon in basically next year or the year after, we will reach something like a 20% gap in supply versus demand. Basically, what it all means in the context that we are discussing today is that we need to rely more on technology, more on understanding, on deep scientific understanding of the problem. When we evaluate technologies, that is, whether they hit the target of um, mitigating the basic risk factors in general and for the individual, rely on what we can do nowadays with databases and analysis of information in databases, and basically stop relying on old-fashioned nursing care of pressure ulcers, um, invest more in prevention and invest more in preventative technologies. And this is the landscape which is changing. And in this context, I'd like now to dive into more of the pathophysiology. There cannot be a more of a biomechanical problem than pressure injuries, pressure ulcers. It's by definition, just the name implies that it's a biomechanical problem, which is for me very appealing because I'm a mechanical engineer by training. So for me, everything is a structure. So when I look at this man, at this person sitting on their couch and enjoying life, I think of their tissues and I think of what their tissue, what the tissues are experiencing. And these tissues are now experiencing distortion at some points at the body of this person to a very high level because they're located near bony surfaces, near sharp, near curved, highly curved bony surfaces, which basically want to indent those soft tissues. But if you could dive into the microscopy of the tissue and look at what happens there, you would see cells, not just tissues, distorted as well. You would see structures within cells distorted because of these mechanical body weight related forces. And you would see even internal organelles within the cell, if you could have that kind of resolution and you could look into the body in real time when we act or when we are in weight bearing postures, you could see those different organelles in the cells actually distorting and changing shape. And when that happens, they don't really know and they also don't really care where these forces are coming from. They can come from the body weight of that person because that person will always have some body weight. And if they're obese, they'll have more body weight. or if the tissues are thin, and then even if they're underweight, they still have body weight forces that, because of the thin tissues, will cause high distortions. So there's always that effect. But that effect can also come from external factors such as devices, as I've mentioned already in the context of literature, device applied forces. Now, think of these biological cells, think of these cells in the cheeks or the chin of that person who's now wearing a CPAP mask. They don't know, nobody tells them that these forces are coming from a medical device. They just know that they are distorted and deformed. That's the only thing that they know. And they will respond in the same way physiologically, biologically, and physiologically respond in the same way, structure and function, as the cells that would be affected by the body weight of that person on the sofa, which means that the pathophysiology in its underlying meaning, the pathophysiology of device-related pressure ulcers and body weight-related pressure ulcers is the same pathophysiology. It's just the origin of the force, which is different. But the pathophysiology happens at the cell level, and at that point, or at that resolution, there's no importance to the specific origin of these forces. And what I'd like to show you is how these sustained tissue distortions, or a more scientific name for them would be deformations, how these sustained tissue and cell deformations are causing damage that can then lead to irreversible damage, that can then lead to tissue death, that then eventually leads to a clinical macroscopic pressure ulcer, and how that process onsets and progresses with time. What you see on the left-hand side is work that I've published with a friend from Finland on tissue distortions in people who lie on different support surfaces. And this is low-dose CT. So you can see the bones, but you can also see the soft tissues. And you can see what happens to the soft tissues when a person lies down, or actually, in terms of achieving the data, when a person switches from a very rigid or a relatively rigid surface to a more compliant or a softer surface. And you can see how much distortion the tissues experience macroscopically. But this is what you see macroscopically. Think about these little region, these small region under the sacrum that you can clearly see at the center of the at the bottom center of the pelvis, at the low CT image, at the low dose CT image, and think about how curved and how sharp it is. Now you can take a pencil and you can push the tip of that pencil towards your finger, and you will experience several things that actually happen at the interaction between the sacrum and the soft tissues. First of all, there will be discomfort or pain, which in most people who are suffering pressure ulcers doesn't happen because of a neurological cause or because of an external cause such as anesthesia, but there will be discomfort and pain, and that will be very regional and localized where the high distortions are. And that's because these high distortions are causing a stress concentration, as we call it, in the soft tissues, which is relatively small physical domain, region, through which a relatively large force is transferred. And so the level of distortion throughout the soft tissues under the pelvis is not uniform. There is more distortion under these highly curved regions than when you move away from these curved regions, which is what you can see on the right-hand frame of the slide. This is a visualization of the phenomenon called stress concentrations, which everybody who was studying engineering, for example, mechanical engineering studies about in the second or third year. What it means basically is that the high risk regions in terms of exposure to tissue loading are near those curved bony surfaces. Maybe up to this point, I didn't say much that is new to you because you've already knew that. But what I like to say now is what these soft tissue stress concentrations are doing is much more than just obstructing or interfering with the vasculature and causing ischemia, which is which was the conception, which was the premise, say 15, 20 years ago. They do much more than that. And in many, many model systems that I've developed throughout my career in my own lab or in collaborations with others, we have consistently seen the same thing, which is even in the lack of ischemic conditions, even if the tissue oxygenation was ideal, cells still died and tissues still died after exposure to a critical level of deformation for a critical period of time, over a critical period of time. And that was only became possible to demonstrate when tissue engineering emerged as an independent field in bioengineering. And there were these big words and very far visions of replacing failing or injured tissues and organs with tissues and organs that will be grown in a lab and so on and so forth. Nothing of that yet to this point has really become commercial or clinically applicable, but we've learned a lot from the methodologies and technologies that tissue engineering enabled. One of them, for me, was the key in the development of my career and research work, was the fact that we could now, instead of doing animal studies, which are stupid in the sense of, you apply a certain load and you're trying to see when will a pressure injury occur. And it does occur, of course, at some point, and you can demonstrate that with histology. And these are the type of experiments that I did 25 years ago or more. But then when tissue engineering came, you could do much more than that. You could apply these loads while super controlling everything in the system. That is, when you apply these mechanical loads on an animal model, as you can see on the upper right frame, you at the same time distort the tissues and the cells, block the lymphatic system, distort the vascular system, create ischemia, change the biomechanical conditions, but also the biochemical conditions. You do everything at the same time, which is what scientists hate, because then you cannot isolate any factors in the systems and you cannot understand the cause or the causes, or to separate the causative factors from the results. But with tissue engineering, you can, because you can, for example, grow a piece of living tissue, say a skeletal muscle or fat. We did both. You can grow them in an incubator, keep them alive for several weeks, study their viability, then apply mechanical forces that would mimic those forces or the level of distortions that an actual person is experiencing in a weight-bearing environment, such as when sitting or when lying, or by a medical device and so on. You can apply those levels of loading, look at the cells as they respond in real time using real-time microscopy, count the numbers of the dying cells as the death wave, as I've described it in the literature, evolves, and then come up with damage laws where you have ischemia, because you've induced those ischemic conditions in the systems, or you haven't those conditions in the system because you did not induce them, because you can perfectly control the level of oxygenation, the glucose levels, the temperature, the pH, and so on and so forth. You can basically deliver ideal conditions to every muscle cell until the moment that they die, so that they will die just because of the deformation. And this is what led to the fundamental discovery that had revolutionized the field of pressure ulcers. And that discovery was joint work of me, of the late Professor Dan Bader from the UK, and of Professor Kees Oemens, who's now retired, that deformation is the primary cell killer. And everything else comes on top of that, including ischemia and hypoxia. And that was a major discovery because it changed textbooks, and it opened new research directions, but it also opened new application directions in terms of how to prevent pressure ulcers. But first of all, we needed to understand how cells die if they don't die because of the lack of oxygen. And this is what you see on the right-hand side of the slide, right-hand side of the slide, where you look at what we have termed what I've called cell torturing devices, which are basically setups that we've developed at different variants over the years to induce mechanical loading to individual cells or to cell groups, to cell cultures. Again, at the same extent that we see physiologically for people. But while we can look at those cells, again, induce the controlled or the conditions that we basically want the cells to experience from a biochemical perspective, look at cell viability and try to understand why these cells are dying. And this, of course, only became possible with the advances in live microscopy, in fluorescent microscopy, and microscopy image processing, which when I started my career were not there. But this is, again, how science evolves, how the auxiliary technologies evolve, or the technologies that we use for our methods evolve, and then we can do more, and then we understand more. And what we understood basically is that what happens to a cell that is undergoing sustained distortion, sustained deformation, is that it accumulates damage gradually, mechanical damage gradually, and slowly. And I like to always explain it using this analogy to a torture rack. And these torture machines, widely used in the UK at the time, are very smart in the sense that they kill you slowly and painfully. And the way they do that is they stretch your skeleton. And they stretch your skeleton slowly until your skeleton cracks. And the skeleton has, as somebody who was teaching biomechanics for 30 years, the skeleton has different roles. It allows you to move. But one of these critical roles is to protect your internal organs. And once the skeleton cracks, it does not have the structural integrity and the structural stiffness to allow it to focus and transfer high mechanical loads throughout the body, which means that now these mechanical loads transfer elsewhere, such as to critical organs, to soft tissues, to the lungs, to the heart, to the liver, to the kidneys. And so while this torture rack works, it diverts mechanical loads from the skeleton of the person to critical organs that are not designed by evolution or cannot cope with these loads, and then they slowly fail. Um, to some extent from a structural perspective, such as tearing of blood vessels, small blood vessels, and all of that, but also from a functional perspective. They don't do what they need to do. The lungs don't do what they need to do. The heart doesn't do what it needs to do, and so on, and the person dies in vain. What is the relationship to pressure ulcers? Well, cells have skeletons called cytoskeletons, which are used for the same function to transfer or to focus on transfer mechanical loads throughout the cell body so that these loads would not affect the functionality of critical cell organelles. And so the vital organs of the person that I mentioned before, which are affected by the torture rack, would be equivalent to the vital organelles of the cell, which are affected when the cytoskeleton is damaged. And what we've demonstrated using these advanced microscopy methods is that you see damage to critical load-bearing structures of the cell. And when that damage starts to affect the envelope of the cell, which is supported by the cytoskeleton of the cell, small holes open in the envelope of the cell, in the plasma membrane, small pores. And that's a critical moment, because that's the moment where the cell loses control. Over what? Over traffic. Over traffic of what? Over traffic of molecules and ions that goes into the body of the cell, or that are lost by the cell to the environment. The cell basically loses control of its biological equilibrium, that biologists refer to as homeostasis, and which is the critical term in cell physiology, the balance between what's in the cell and what's out of the cell. And that is compromised seriously when there are integrity type of damage accumulating over the surface of the cell. And that poration of the plasma membrane of the envelope of the cell happens relatively quickly, within minutes, and within a time scale of tens of minutes or 10 minutes, the cell dies. And that has nothing to do with the concentration of oxygen around the cell or within the cell. That has to do with the fact that the cell cannot balance, for example, traffic of calcium, which can be cytotoxic, into the cell body from the extracellular space, and the same with other molecules and ions. Actually, every cell has a very delicate and precise mechanism for controlling anything that goes out and that comes into the cell. Basically, doors and windows with fancy names such as basically enveloping the surface of the cell to encompass molecules from the environment, and endocytosis and so on. And once these are not functional anymore or not important anymore because the doors and the windows have been left open, or because now there are just holes in the wall, anything can happen. So you can think of a house where there are doors and windows, but now on top of the doors and the windows, which can be closed, there's a hole in the roof. Then the rain and the snow can start affect the integrity of that house, and this is basically what happens here. So to summarize this, which is a critical point because it also leads to application points. To summarize this, the cell loses control over transport of molecules and ions, thereby losing its biological equilibrium, losing its homeostasis. and then cell death occurs. And if you understand this process, then the rest, I guess, is straightforward to understand, because then it's just a question of time until a mass of cells dies because of this deformation induced cell death. And when that mass of cells, that mass of first cells dies, the body responds. The body detects and responds to it by triggering the inflammatory system, which is a physiological or a pathophysiological normal reaction to um, death of a mass of cells for any reason, by the way, not just because of mechanical factors, as in this example of pressure ulcers, but also if that was a death caused by pathogens and so on. And so what the body wants to do is to recruit white blood cells of different sorts, of different types, attract them to the damaged site, and find out what is going on there, what can be done to fight maybe a pathogen or to repair the environment or to clear the debris of the dying cells, basically to prepare the ground for regeneration, for tissue regeneration, for formation of scar tissue, and so on. But the white blood cells, they reside in the circulation. And for them to arrive into the damaged site, wherever that was, say on the sacrum, as in the example that I've started with, they need to reach that point that is closest in the circulation to the damaged site, leave the circulation by crossing through the border of the blood vessels, crawling their way to the damaged site and acting there. And for that, the body basically relaxes the blood vessels that are near the injury site, the initial damage site, which makes them more leaky because there is no more such tight forces joining the cells of the vessels together. And so these leaky vessels now, as a byproduct of their being more permeable and allowing the white blood cells to leave, are now basically causing accumulation of serum, or plasma, sorry, in the interstitial space. And that plasma, when it accumulates to a critical level, is now becoming edema, which is, again, a perfectly normal phenomena of buildup of fluid. That's because the body responds, because the inflammatory system works. That's fine. But not so fine in the context of pressure ulcers, because always in a pressure ulcer scenario, that happens between two surfaces. The tissue is sandwiched between two surfaces. A surface that is internal, that is the bone, the bony surface. That's what have caused all these mess on the first place. And there is also an external surface. That can be a mattress or a wheelchair cushion or a medical device, anything on which this person is, by which this person is supported, or in which this person is lying, or which is applied to the skin of that person, again, a medical device. But the soft tissue is always in the middle, is always within the sandwich between these two relatively hard surfaces, relatively stiff surfaces. Now, when the blood vessels become leaky, and interstitial fluids accumulate, the pressure rises. And it must rise because the tissue cannot expand. There's no swelling as you would see when you hit the toe in your foot at the leg of the bed, and then your toe swells. That's again edema, but that's edema that is free to develop because nothing confined the soft tissues of your toes. But in this situation, the tissue cannot swell because it's sandwiched, and then the pressure rises very, very sharply in the tissue. And then there are more cells that are distorted. And then there is more deformation-induced damage. But also at some point, pressures are so high that they obstruct the vasculature. And then comes the story of the ischemia and the hypoxia. Rather late in the process, it's not that it's not existing, it's there, but it arrived very late after all that damage that has to do with the direct deformation and with the inflammatory response has happened already. If you understand that, then you also understand what we need to do. We need to protect those cells and those tissue regions within the high deformation sites, the potentially high deformation sites. So we need to know, we need to understand where should the high deformations in soft tissues occur. Well, actually, epidemiology gives you a simple reaction to that. Um, we know that these happen under the sacrum and also under the calcaneia in the heels. But now you understand why. You understand that this is because these are highly curved bony surfaces that are covered by a thin mass of soft tissue where there are very high levels of deformations locally, sustained deformations, which start this vicious cycle that I've described in the literature for the last 20 years. And again, this is all true also for medical devices. With the same processes that I've described occurring in both weight-bearing related and medical device related pressure ulcers. And we could see a very impactful demo of this during the COVID era, where we saw that these list of suspected medical devices that were highly suspected before and then were used in such huge masses over so many people, such as ventilation equipment and so on, indeed caused massive pressure injuries, especially for COVID patients, because their inflammatory response was impaired or abnormal, causing more leaky vessels, causing more edema, which accelerated the pressure ulceration process, which then caused horrible wounds. If you put all of that in scientific terms, you get something like this, which describes the process on a time scale, starting from the deformation, initial deformation damage, progressing into the inflammatory damage when the inflammatory system kicks in, then progressing to ischemic damage, but eventually these three components of the damage are all factored together. They're all acting cumulatively to create a cumulative damage effect, which grows non-linearly and depending on the individual, which also tells you why it is so difficult to predict a pressure injury event in an individual, because everybody responds differently in terms of when and how much of the direct deformation damage they will suffer, and then how their inflammatory system will react depending on their own physiology and also on the treatment that they're receiving for systemic conditions, from chemotherapy to any other drugs or pharmaceutical interventions that affect your inflammatory system. We're speaking about ill people, about patients. And then the ischemic damage, which again depends on your cardiac function, your cardiac output, but also the quality and density of your vasculature and the function of the vasculature, which is again affected by the individual diseases such as diabetes or peripheral vascular diseases, and so on and so forth. It's such a complicated puzzle. But we can simplify all of that to just refer to the point where it all starts, to the turning point where all hell breaks loose, which is the beginning of accumulation of the deformation damage. That's the ideal point of intervention, the red point. And if you can postpone that red point over time, then you postpone the whole thing. And basically that's the purpose in pressure ulcer prevention, in advanced or modern pressure ulcer prevention, is to postpone that point in time, not to make it go away, not to make it disappear, because that can never happen on this planet because of gravity, at least when in the context of weight-bearing injuries. But we can postpone it with the right technologies. And then the question, and that's becoming more of an engineering question, okay, but how do you postpone it? How do you know that you've postponed it? For that, you need to know what the loading state in the tissues is, and then by how much you improved it because you did something. And there are established methods in engineering for doing that. Some of them um, you've seen, I'm sure, in your professional life. They are based on computational methods. You design everything nowadays with computational methods, and bioengineers have started to understand the usability of this when it was used first for in civil engineering or mechanical engineering applications. Then we understood that we can also do it for living organs and tissues. And then, of course, if we can do it with living organs and tissues, let's look at the interaction between implants and tissues. And this is, by the way, as somebody who's consulting frequently to governments and to the FDA on safety of implantables and medical devices in general, I can tell you that if I see a file, or if somebody is at the FDA see a file of an implantable without a thorough analysis using computational methods of the interactions between the implant and the surrounding tissues, such as for stents or for orthopedic implants, the file would not proceed. That would be the no-go point. Um, and so what I thought at some point years ago was that if we can already do that so efficiently for implants, why do we not do that for surfaces, materials, um, for any element that is contacting the body on its exterior surface, on the skin. So that can be a mattress, that can be a wheelchair cushion, that can be a positioner, that can be an operation table pad, and that can also be a dressing, especially a dressing that is used prophylactically to redistribute the state of mechanical loading in the tissues. And then indeed we started to do that in collaboration with industry, and many years ago, and I'll just show some recent examples. What happens to the tissues of the sacrum when somebody is sliding in bed, and you can actually quantify that. So again, maybe Homer Simpson in this case is an animation, but what you see on the right side is not an animation. It's not a Walt Disney thing. It's the physical interaction quantified, considering the stiffnesses of the support surface, of the soft tissues, the anatomical structure there, then demonstrating what happens when a person slides in bed in terms of the loading state in the with emphasis on the shearing loading state around the sacrum. And you can also consider anything that you can do in terms of lowering the head of the bed, or using another cover, or using another mattress material, or anything else, or putting a prophylactic dressing, of course. Anything else that you can think of, you can include in this simulation. It's just a matter of time and money. And you can measure, quantify how that would affect the exposure to internal tissue loading. And over time, we have also learned that temperature is important as well. That the rising temperature when a person is interacting with the support surface, and the time course over which that happens should also be considered. And then we've started to develop what we call multiphysics models that not only concern the mechanical interactions, but also the thermal interactions, which, by the way, affect each other, which is why we call it the multiphysics problem.